Thank you so much, Amanda. I'm going to take my prerogative as moderator to ask a quick follow-up question to each of our panelists, and also to give all of you a moment to gather your thoughts for the comments and questions that we'll be taking from the floor. There are two interesting themes that I think came up across a number of the panelists. One is, in some ways, a feel-good story. Right? We've heard a lot about investments being made in capacity, improvements in capacity, learning over time, new arrangements put in place to work across sectors. So on the one hand, it sounds great, right? We're ready. Hong Kong and Liberia and Saudi Arabia are ready, it sounds like, for the next outbreak that's going to come down the line. And I'm wondering if, at least for the first three speakers, is that right? Is my optimism appropriate? Or are there some other challenges that we haven't yet put out on the table? And I think the one that I'd like to pose to Amanda in particular is around the issue of community mobilization. You mentioned, and we were chatting earlier about the issue of if there is weak social cohesion, if there is perhaps in a situation of conflict or post-conflict, and certainly that's relevant for some of the concerns in DRC today and in other parts of the world, how feasible is it to engage in mobilizing communities to communicate appropriately regarding behavior change, et cetera? How much more challenging is it? What else can be done if you don't have that basic fabric? Is that something that we have figured out as a global community? Second, my specific question to Gabriel, I'll give each of you just a minute to think through your answers, is it does sound like Hong Kong has really learned a lot from having been hit multiple times. And in many ways, you can imagine that countries that have been burned, you would expect there to be investments in capacity. I think one of my key questions is, how do you convince leaders of countries that perhaps have not had such a trial by fire, in a way, to also make those investments? Is it possible, or do we need to really wait for a catastrophe to hit each country before those capacities are built up? To Masoka, I think one of the the many hats that you're wearing that I didn't mention was as co-founder of the National Public Health Institute, of Liberia, which did not exist prior to 2014. And it would be very interesting, I think, to hear what is an institute like that. What was your motivation behind pushing for the creation of an institute like that? What role can a public health institute play in addressing some of these longer-term concerns, particularly in a very, very resource-constrained setting where there are many other competing priorities? Universal health coverage is, of course, a big one on the agenda, certainly in many countries around the world. And is there a way to square the circle between investments in preparedness and investments in day-to-day provision of healthcare services, particularly when resources are so tight? And then my last question to Dr. Asiri is, it was quite amazing to hear about the measures that your government has taken, particularly in relation to the Hajj. Has MERS become the new normal? Is the country, are the measures in place enough to keep it at a very, very low level? And are pilgrims who come to Mecca, for example, comfortable enough with the risks that they face so that it does not actually affect travel? I think one thing that's striking to me is we often see that trade and travel drops very quickly in the event of an outbreak, certainly of a novel pathogen. It sounds to me like that's not necessarily been the case, but please correct me if I'm wrong. To what extent has this become a perhaps semi-permanent part of the health landscape? Is that correct? Is that not correct? Are there still adequate measures being put in place to make sure the level of infections remain very low? So I'm going to ask Amanda to start, and then we'll come down the line. Thanks.
The easy question of how you build social cohesion. I think my first reflection has been, I started my career with the Red Cross in natural disasters, and how different working in a natural disaster and an epidemic can be. So within a natural disaster, we see communities that potentially didn't have good social cohesion come together around the crisis and really work together. So you can build social cohesion and you can really unify a community around a common cause. we don't really see that in epidemics in the same way. I've seen it in Somalia around cholera. It was amazing to see how communities came together, but the level of social cohesion was fairly strong before the epidemic. We've seen back in 1918 and major epidemics all the way through that even with good, strong social cohesion, it's easily destroyed by lack of trust and poor messaging. So even if you have good social cohesion before, it doesn't mean you keep it throughout the epidemic, although it's helpful. I think one of the things we've been talking about more in the social science side is the concern that as we've promoted the integration of social science more into epidemics and the lessons that we learned from Ebola, it's been relegated to risk communications. And I would much rather see social science move right into the Emergency Operations Centre as part of incident management and be used for every part and every pillar of the response. It affects every non-pharmaceutical and pharmaceutical measure, whether you quarantine or quarantine a hotel, shut a school, ask people to wash their hands. There's a social aspect of that. And I think we need to do a better job of integrating our social science information into our behavioral the dynamics of transmission, and better monitor the flux of social cohesion, because it's not a static measure.
So Suri asked two questions. One, is Hong Kong as ready as we appear to be for the next big thing? And two, how do you persuade governments who may not have been hit like Hong Kong had been with a few big ones? So the first answer is really Hong Kong is not as secure as it looks for two reasons. One is if you just look at the whole network of interconnected cities and villages in the Pearl River Delta, the total population at present is just under 80 million. Hong Kong has about 10% of that, 7.5 million. So we're only as safe and as secure as the weakest link in that entire area. And two, can you scale Hong Kong's experience even if you have all the money in the world? It's not a direct translation. So whatever you see Hong Kong, or for that matter, our great sister city, Singapore, can or have done, you have to remember that these two places are 7.5 and 5.5 million people, respectively, in a hugely, hugely larger and more densely populated hinterland. And both places import 95% plus of our food. And therefore, especially if you look at it from a One Health approach, we're probably not as secure as we should be or could be. Secondly, I shared experiences about directly transmissible respiratory pathogens. I didn't tell you anything about vector-borne diseases, for example. And in my part of the world, it is also a big problem. So there are some sort of mysteries which I have always sort of struggled with. Number one, why don't we see Zika babies, notwithstanding the fact that we have tried, we don't seem to report as many as we should be seeing, given the prevalence of the vector, the ecology, and the bug, obviously. Where is yellow fever in Hong Kong? Or for that matter, in southern China? And dengue, we have a vaccine, but it's not a very good one. Singapore halted its vaccination program, even though it has a very, very large dengue burden. What to do next? And finally, how do you go and persuade government? I think that if you've been hit several times, and don't forget that Hong Kong actually was the place where the plague bacillus was finally identified back in 1894. Since then, we've had obviously the Hong Kong flu that was talked about this morning in '68, but also we've got 97 H5, we've got 2003 SARS, we've got 2009 pandemic, and the occasional flare-ups of H5 outbreaks. So once you've been through so many things, it's not difficult to go and persuade government. And finally, let me just say that Hong Kong is one of these places where economics matter a great deal. And when you have the 2003 SARS experience, with the economy taking such a huge hit, and in fact, an entire government falling, in part at least, due to SARS, right after 2003, then it's not difficult to persuade governments if you have had that kind of experience. If you haven't, just point the finger to places where you have had such painful experiences. And I think the precautionary principle, or at least the fear factor, probably would be able to persuade most sensible governments.
Yeah, thank you very much. The reality is that our preparedness is very fragile, I have to admit. I will give you a typical example. Say the southeastern part of our country, if there was a suspected EVD, the sample gets picked up by the surveillance officer. That surveillance officer is currently being paid by World Bank and part of the money from CDC. The sample gets on a relay system that takes anywhere between 24 to 76 hours to get to the lab. The group implementing that, called Riders for Health, is being supported by CDC through an implementing partner. The sample gets to the lab, it has to be analyzed. The reagents for the analysis of the samples are all provided by DOD, CDC, and NIH. So you see that every set of the way from the preparedness is dependent on donor, the funding they provide. Every time that changes, our preparedness goes down. So last time I presented a slide I have where I showed that there was a period of time we couldn't get funding from the World Bank WHO. Our completeness and timeliness dropped from 95% to 13%. That is the timeliness and completeness. That's the first factor. The second time, last week, we had chlorine spillage. There was a huge spill out of chlorine. 64 persons got infected. And then I was in the US and I wrote to the response team, do you guys have masks? Have you called them the first responder, the fire service? It will shock you to note that none of the fire service had masks or oxygen. So basically, it shows that preparedness in terms of chemical, nuclear, biological, and radiation. So we have this skewness, we have the public health preparedness moving this way, environmental, other calamities are dying. And so we use that now as a platform the last time to set up a team to look at a complete hazard, multi-hazard risks. So first factor is it's heavily dependent on donor. Two, preparedness is skewed. On one side, you have the public health response better, but the overall multi-hazard response is still fragile. The third is that, again, thank God for Ebola, we've seen our ability and our capacity to diagnose in the public health lab has gotten better. Our public health diagnostic capacity has gotten better. Unfortunately for us, our clinical laboratory, our frontline laboratory where the patients will go for the first time are still struggling. So that would mean that in most of the responses we had, we pick it up after a cluster of death. I'm not comfortable with that. We should be able to pick it at the earliest point because basically there are no labs in the clinics and so patients don't even have good health-seeking behavior. So we have a success in some area, but it worries me that today, if all of the funding was to go down today, until we can begin to discuss from a global perspective that how do we provide some kind of long-term funding mechanism, we'll begin to work with government to commit. And that will lead me to my second point. I have to admit that the government of Liberia has done well to commit to the National Public Health Institute. We're a new institute created as a result of Ebola, and basically it came from the fact that the public health threat sort of crippled our entire health system. All our major hospitals shut down as doctors were dying. Basically, the health system could not. And so the idea was that let us develop a group that will be narrowly focused on early warning, on surveillance system. We did that in about 15 months after we decided to in Thailand and in Norway to study that model, and we came back. And you know, they say usually to make policy change, it depends on the context and the ethos. Ebola was there was a context, and I have to agree that all of the actors felt the need for us to have an institute, from the president to the Minister of Health, CDC, WHO, and all our key partners supported heavily for us to move to that, so that was critical. And then once we developed that, the government committed a budget to that. Now you come to the key point you raised. I can't remember lying down one day, I wasn't well, when I got a call from the Minister of Health and said, you have to come to the Capitol building to the legislature. So why? They said, because I just realized that you guys, as a result of the Public Health Institute, they have slashed half of my preventive health budget. I had to go back to the Senate and go to defend before the Senate why we needed this amount of money. I told them at the time that there was dengue in Cote d'Ivoire, that brought stands as a risk. We have 1.5 million febrile cases a year that does not get diagnosed. I had to build a strong argument to keep the budget, but that has still left to some. We still have political struggles. And, you know, like I explained to you, the issue of, yes, so well, we're doing better now. Our system is getting robust. We got partners supporting. But the idea now is our regular health services is still struggling. Laboratory, supply chains. And so how do you make that fine balance is going to be very critical. Because the thing is, if you all invest in preparedness and early warning surveillance, emergency doesn't always happen. I agree it happened once, and the consequences are hard. Do you put the resources into emergency preparedness and response and neglect the regular routine health system? That comes with a price, because then the health-seeking behavior of a population gets compromised. And so if there's outbreak, they don't go to the clinic. They go to the herbalist and the disease spread. So that's the tension we are going through. We've made some progress. We are prepared, but it's a fragile preparedness that needs to progressively require innovative thinking. Thank you.
Yes, I mean, the issue of MERS and Hajj, I think we are much more worried about influenza when it comes to Hajj. Having no sustained human-to-human transmission of MERS made it much easier to control it when it comes to mass gathering, because we were able to declare the Hajj zone as a camel-free zone, where we had to enact laws to prevent the importation of camels into the Hajj area. And this, of course, has drastically reduced the risk of MERS-CoV transmission from animals to human. If you ask me, are we prepared for the next pandemic? I can say that for MERS-CoV, we are in a much better position to control outbreaks, because most of the investment has been done inside hospitals to improve healthcare, infection control in healthcare facilities. And this has resulted in a dramatic decline in number of MERS-CoV. In the last 2 years, we did not have any major outbreaks. But the continuous spillover of the virus from camels to human is now accounting for more than 90% of the cases, and continues to be, a public health threat. So yes, we had significant improvement, but it is a tunneled improvement focusing on MERS-CoV. We had a great difficulties in expanding the preparedness to other infectious disease, let alone the other all-hazard approach that we are trying to build in. So yes, we are in a better position in some aspects, but we still have a long way to be prepared for non-MERS-CoV threats.
Thank you very much. Let's open the floor now for questions, comments, challenges, disagreements from participants, and we'll start with Jonna Mazet.
Now, can you hear me? Jonna Mazet, professor at University of California, Davis, where I also direct the One Health Institute. I wanted to thank the panel for inspiring us somewhat with these hard stories and lessons, but really great messages. I want to just start with, I think I completely agree with Amanda. If I could restate that politicians currently hold the keys for our global health security. That's where the power is. But given that politicizing diseases can have and has led to campaigns that promise absence of disease, I wonder, that has huge issues with potential information sharing and interventions down the road. And so I wonder how we as the global health community can be helpful. We don't have the keys, but how we can be most helpful to empower the communities to embrace their real strength, and prevention and preparedness to limit sort of the political posturing and the conspiracy theories that lead to divisiveness and lack of effectiveness of interventions.
Thanks very much, Jonna. Are there other, I see, sorry, I'm not wearing my glasses. David, yes, in the back. Yes.
Thank you. Dean Leung, as a clinician, I was struck when you said that more than 9 out of 10 of your hospital admissions are seasonal febrile respiratory illnesses at one point. I'm curious, for whatever that number is, what has been the impact on other health services in those settings, and what has that collateral impact meant in terms of your all's thinking and understanding of clinical preparedness in epidemic settings?
Thank you, and we'll take one more from KG on the other side of the room. Okay, KG.
So one of the long sought after things in global public health has been to do capacity building. And it's really tough. I mean, you have OECD approaches, you have IHR, JEE is another offshoot of, it's basically a child of GHSA and IHR kind of combination of things. And yet capacity building remains difficult and fragile in a lot of ways. And I think that the question is, it's clear you need several things. You need leadership, you need money, you need culture, you need people, you need all of these things. But I think the practical issue is, what in your experience has been the key for leading to that process where you get a decision or an actual movement towards capacity building in countries? Is it getting to the leadership? Is it having the community's voice that they're unhappy? Well, so I'd really love to hear in each of your experiences, what has been the key thing to get things moving? And then it goes back to Suri's question, because you can't use a crisis and count on every country to go through a crisis to get to capacity building. So what's the essential ingredient to sort of move countries in a way? Because they're not all rational. All governments are not rational. They don't listen. They are an entity in themselves. And so I'd love to get a sense of how you think about those.
Thanks very much, KJ. I think that's a question that all of our panelists could respond to briefly. So actually, why don't we start on this end, and we'll have you respond to the questions that that were relevant to your particular experience. Dr. Suri.
Yeah, I think to the question of KG, I think the only way to maintain the advocacy is to keep them in their toes. I think, taking our example, in my country, 7 ministers were sacked because of MERS-CoV. 7. So this has led to a change of thinking. 2012, before 2012, only 9% of the government, of the health budget, were directed to public health. Now it's 70%, just because of MERS-CoV. And this has also changed the way that the other non-communicable diseases are addressed, because the whole concept of channeling the funding has changed dramatically towards public health. So there is, I think, what we have to do now is to keep the momentum, keep the public health always in the top of the agenda. Keep also the media, especially the social media engaged. I think that they are in a position to, affect the whole, line of thinking in the government and in the politicians' mind. So keeping the advocacy continuous, keeping the public health agenda on the top of the government, and also the joint external evaluation has helped us a lot. It was, used as a tool to keep the thinking towards public health. We heavily, invested in the publications of the joint external evaluation. How did we do compared to other countries? Although this was not the intention of the joint external evaluation, but we used it to foster the interest into public health and keep the interest of politicians very high to keep the momentum.
Yeah. Well, they say the way you convince politicians is always to give the economics of the disease. It's always. I can remember during the outbreak that we had next to the airport. The president was very concerned because it was a time we had a Norwegian building the hydroelectric plant. And they had said that if we did not contain the outbreak, they will leave. And so it has strategic importance and we have to have the resources. But more besides, I can speak from the perspective of sub-Saharan Africa. The more we've gotten a sensitive surveillance system, the more we are picking more diseases. And that's why we begin diseases that did not exist, we are not picking them. For instance, we thought that there was a meningitis belt. But now we have 3 cases of meningitis that were linked to the stream from Niger in Liberia. And so the more our sensitive system, so we have this feed-forward system. We've developed sensitive surveillance system. Therefore, we are seeing more diseases. And the diseases come through the weekly bulletin through our RDSRO system. And so it comes before the politicians every day, they get briefed. And, for example, we've been having almost for a year now measles outbreak. Now we reconfirm meningitis. I've just said to you this year alone, we have 47 different outbreaks. And so what I've done for Africa is that because there's been some sensitivity by building some initial capacity, it is now forcing people to question the issue of more capacity, both at the regional level. For example, now there is a mandate within WAHU that for every 100,000 people, there should be 1 trained epidemiologist. This has been complemented by the African Union, the African CDC. Last week, I was in Mozambique at the Africa Epidemiology Network, AFINET. And that's the goal, to get AFINET center in each of the sub-Saharan Africa so that we can have a free epidemiology string. So the resolution has been developed. We call it the Maputo 2018 to spread. So it's a kind of a feed-forward system, better surveillance system, more diseases in sub-Saharan Africa, and so it's pushing partners and national government to know that they have to invest. And then the issue of information sharing. I'm proud that you gave this very interesting piece. We had meningitis outbreak right at the border where Ebola started from, between Liberia, Sierra Leone, and Guinea, when we confirmed 8 cases of meningitis. However, it was the day before the inauguration of our new president. So then we sat down with CDC and WHO, who said to us, we are under obligation to report this. And we said to them, gentlemen, tomorrow is our inauguration. Presidents are flying in country. Do you want to release this message today? Then we took a step back. Let's ask ourselves a fundamental question. Is the outbreak contained within a geographical area? Yes. Have we provided chemical prophylaxis to the contact? Yes. Then we ask them, give us 48-hour news freeze. Because again, it has security implication, economic implication. So we all agreed, and I said to them, so take it like this. We have not reported to you a case here in the lab. We'll get you the case in 24 hours. So the way you share information is sensitive. We have inauguration going on. Presidents have flown in. If we had just said outbreak, even though we'll have said meningitis, but the fact that Liberia had Ebola, it would have disrupted our inauguration. So one time I was presenting to the vice president and said, Madam President, while you were at the stadium smiling, I was struggling to contain an outbreak. She's like, is that for true? I said, yes, but these are the things we can tell you. We do them on the side. So information sharing during an outbreak becomes very sensitive. There are security implications, there are economic implications, and you owe it to the global community. So it's that fine balance to manage during outbreak.
All right, let me just try to answer bits of all 3 questions. How do you get governments, other than the fear factor or looking at economics? I think there are 3 levels. One is you go directly to the people. So the comment about social media, the comment about media generally, it's the direct sales model. And that's why I spent quite a bit of time talking about directly and proactively engaging with the population. I think that's very important. And ultimately, whatever kind of regime your country may be under, there is a lot of potential, at least, in terms of the power of the people, if you can get through to them the importance of pandemic preparedness. 2, I think from the global health community at the technocratic level, I think it is absolutely crucial. In addition to the audit-like exercise of the JEE, I think that it is very helpful if we have a lot of links, relationships, and exchanges and sharing at the technocratic level. And building capacity through these relationships that during peacetime you build, or as a result of having gone through together a major epidemic, I think those kinds of relationships are absolutely crucial to keeping and reinforcing the local capacity building effort. And then thirdly, I think is use supranational agencies and multilateral agencies as appropriate. So regardless of what the 196 or so countries or member states really think about AMR, the fact that KG and Margaret took it to the floor of the UNGA meant a huge amount. Did it achieve a lot? Probably not at the technocratic level. Did it bring about a lot of change on the ground? Not yet. But it was the third topic, health topic, to have hit the floor of the UNGA, which is in itself, I think, carries with it a certain political significance, which you can then follow up on. So I think at these three levels, it's where we can help or cajole or prod local governments or countries to act. And then just going back to clarify that number, 9 out of 10 of all admissions in Hong Kong take place in public hospitals. And what I was referring to was one of the ways that we deal with the annual surges, either the winter surge or the winter and summer surge, depending on the shape of the flu season in Hong Kong, was and still remains universal testing of all respiratory cases that come in through the door. But even then, you see the picture that I show you, which is not actually an uncommon sighting during the flu season.
I think I would challenge how easy it is to mobilize the community to care about pandemic preparedness unless they've just been through a major risk. I think, and for me, in terms of mobilizing governments and mobilizing communities, the biggest entry point is their perception of risk. And if we're using fear and the risk of an epidemic or the risk of economic loss or the risk of, we've talked about several politicians losing their jobs, both in Hong Kong and Saudi Arabia. So we motivate politicians because if you don't do it, you potentially lose your job. Everything at community and at government level is balancing risks and prioritizing behavior change. What are they going to do personally and as a system to protect themselves? And I think it's easy post-Ebola to highlight the risk in Liberia of public health. But as malaria deaths surge well beyond malaria, as maternal and child deaths go back to the levels that they were pre-crisis, it's very hard as a politician to prioritize an EOC that you turn on once a year against mothers that are dying every day. Much easier to mobilize a community to demand better maternal health care because everyone knows a mother that died in their village than it is to mobilize a community against Ebola, even at the scale that we saw in West Africa. So, I think part of this for us is taking a strategic view, country by country, community by community. What are the risks? What are the risk perceptions? What is the choices those communities and those governments are making to prioritize preparedness above other health risks or other economic or safety risks? It's difficult in DRC to prioritize Ebola preparedness above not getting shot every day. So, what do you do as a community in terms of prioritizing? And I think we learned this really the hard way when we were doing, I was in charge of safe and dignified burials for the Red Cross, and we buried 55,000 people across the 3 countries. And as we worked with communities, they were making decisions every day, and the risk of burying one of their loved ones with no protective equipment versus the risk of that person not going to their equivalent of heaven. And they were weighing those risks with the knowledge on both sides, and they chose to take the risk to get Ebola. So each community, each government, they measure that, and I think we have to, because the Hong Kong government, has had their risk in Hong Kong is different to the risk in Sierra Leone or in Chad. You can't motivate the government in Chad to invest in preparedness the same way that we can in Singapore or Hong Kong. So it's country by country, community by community. But I do think the JEEs have had a big impact, and I'm really happy to hear how successful Saudi Arabia was to use it. We've seen a lot of engagement at high levels when we're able to compare. I think we've underestimated competitiveness against risk, and being able to show country by country how, the JEE is not made for comparing, but let's be honest, we all do it, and we're using it as a motivating factor. The fact that we're up to 86 JEEs and they're gaining more momentum, it'll be important that we're able to show progress as we enter the second round of JEEs.
Thank you so much. We've reached the end of our time, but I think since we started 10 minutes late, Dennis has a burning comment. Burning? Okay. And then I'll offer a few closing summary.
Hi, Dennis Carroll from USAID. When we talk about community, I wanted to drill down to a very specific subset of the community, and that's the business sector. But in SARS, we saw an enormous impact on global supply chain. And in West Africa, we saw the extractive industry come together initially, followed by the agribusiness and other communities, that there was enough recognition about risk and risk vulnerability that they self-mobilized as a way of trying to risk mitigate. And going back to KG's question about how do you sustain this issue in the absence of immediate crisis, how do you harness the power of the business community in their own self-interest in terms of risk mitigation? Business continuity plans from healthcare on to manufacturers, travel industry, et cetera. The role that they play, not just during, but then after, the issue about sustained preparedness within the business sector and how that can then influence politicians as well as other community sectors.
I think certainly an important theme that segues nicely into our next session. So I'm going to call the end and end this session and just offer a few quick conclusions based on the remarks that we've heard. I think on the encouraging side as reasons for optimism, we've seen a lot of improvements in capacity. We've seen a real capacity to learn, whether that's through informal tacit knowledge or formal studies and evaluations of strategies that worked across all three countries that we've been talking about today. But there are also, of course, a number of ongoing challenges and weaknesses. And I think the first is that my personal conclusion and belief is that we might fervently wish for the issue of outbreaks to remain high on the political agenda. And we can pull out economic models, we can make all the arguments about political cost, et cetera. But at the end of the day, it may not remain very high on the political agenda. And I think that's something that we need to be clear-eyed in recognizing. I think what we know from many, many studies in public policy is that you need to put in place and institutionalize changes when the window opens, which is usually after crisis. And institutionalization can mean funding, it can mean policies, such as the JEE, it can mean the creation of organizations, such as the National Public Health Institute, that those longer-term efforts need to be put in place in that short window that's going to close. I think one of the last reforms that has been made is actually to try to strengthen international accountability for preparedness through the creation of the Global Preparedness Monitoring Board, which was just created earlier this year and is kind of starting to get rolling. So I do hope that will help us institutionalize some of these attention to weaknesses so that we don't keep repeating history. The second big issue is, of course, or conclusion is that national capacity is both simultaneously an extremely local issue drilling down to community level, but it's also very much an international issue. And I think what we heard was not only the importance of these accountability efforts between countries, and I'd like to just remind people the JEEs, I believe, we're now at about 80 countries that have participated in JEEs, but that's out of 194 member states. So huge progress on the JEEs, a very, very important shift, but less than 50% of member states who've completed those. But we've also heard, of course, about the importance of international collaboration. I think Gabriel was reminding us that that is, in fact, a way to build capacity, that national capacity building need not only be a national effort. And then I think the last point that came out very strongly was the risk of harmful competition between different health agendas. And many of the people in this room are here because we believe that outbreaks of infectious disease are an important health issue. So in some ways, we're preaching to the choir here, and we're speaking amongst ourselves. But very clearly, it's certainly not the only one. And I personally believe that in order to make investments in preparedness stick and politically sustainable, they have to deliver short-term benefits for populations. They have to deliver better health care today, and we have to get very smart and very specific about what are the investments that can offer dual benefits today, but also in terms of preparedness, that making that choice between the two is an impossible choice, particularly in some of the most resource-constrained settings. So with that, please join me in thanking our panelists. And I think we'll now move to the next event.